It is the voice of Indiana County, WCCS, AM 1160 and 101.1 FM. And Dr. Dan Clark is here. If it's 8:10 on an October Wednesday, our new tradition that we started last year must be in effect again. Good morning.
Good morning.
You are here today to talk about a very, very serious topic.
Right.
Breast cancer. But a topic that at one time might have been thought to be a topic with very little hope attached to it. But now...
Correct.
It's a whole new day, isn't it?
A completely different story nowadays. You know, we have the reason we have so many survivor events, like I tell my patients, is because our survivability from breast cancer has increased dramatically over the last 10 to 15 years.
Yeah. Dr. Clark is the director of the IRMC Comprehensive Breast Center. And just in the last year, the capabilities at IRMC have increased in a magnificent way.
It's been fantastic. You know, I was here a year ago talking about what we wanted to do, and it's amazing how much we've accomplished in the past year. The administration has been so supportive. The Healthcare Foundation, the IRMC Healthcare Foundation, has really been supportive with things. And we've added a lot of services over the last year to the point where we're very close to applying for the national accreditation for breast programs.
How about that? How about that? I know that was one of your goals when you first got here.
Right. You know, and I talked to administration before I came and said, you know, if you want me to come, we need to work toward this. And little did I think that within a year's time, we'd be close to applying. It's a very rigorous, you know, regimen you have to go through to get to that point. But they've put all kinds of effort, and, you know, we truly are a comprehensive breast center now.
When we talked last year at this time about breast cancer care here in Indiana County, 3D mammography was just becoming brand new at IRMC main campus.
Right.
Since that time, it's now available at IRMC at Chestnut Ridge.
Correct. Yeah, we installed it in the Blairsville office in January. And I'm also happy to report we're getting a second 3D mammogram unit at IRMC as well. Our volume has increased to the point now that we need a second unit at the main campus as well.
Which means the message must be getting through.
I hope so, yeah.
Yeah. So what is that message to women out there who are reaching a certain age, but certainly all women need to hear the message? What is the message they need to know about breast cancer?
Well, with no family history, you know, you really should get a mammogram beginning at age 40 and yearly thereafter. As you know, there's been a lot of confusion. There's been a lot of different messages coming from different organizations about when to get a mammogram, what's the appropriate age. So an organization called the NCCN, which is the National Clinical Cancer Network, which is made up of the largest cancer centers in the country. You know, MD Anderson, Cleveland Clinic, you know, all those big places, Sloan Kettering, got together. There's like, I forget how many, 15 to 20 of these major cancer centers across the country reviewed all the guidelines from all the organizations, the governmental guidelines, which we talked about last year and how ridiculous those were, but all the American College of Surgeons, the American Academy of Family Practice, they reviewed all of them and looked at all the research and came out with a very strong statement saying that the recommendation is every year beginning at age 40 for the rest of your life as long as you're healthy. You know, because some of the guidelines say to stop at age 70, some 75. But, you know, a healthy 75-year-old needs it more than somebody who is a very ill 60-year-old. You know, so, but as long as your, you know, life expectancy and your health status is there, that you should continue lifelong.
Absolutely, absolutely. And of course, the 3D mammography is one very, very important part of a big puzzle that is being put together at IRMC having to do with breast cancer care, because it's a comprehensive, you use the word comprehensive, and that's the appropriate word, isn't it?
Right, because I wanted to stress that, you know, it's not just me, it's not just breast surgery, but we truly have all aspects of breast cancer treatment at IRMC now. You know, it is truly comprehensive, and, you know, the other thing we wanted to mention is that not only did we get 3D mammogram, but, you know, previously we had to send women out of town to get breast MRI. And in February of this year, I'm proud to say that the administration installed a brand new 3D breast, or not 3D, but a brand new breast MRI unit at main campus as well.
Yeah. Let's talk about that in relation to 3D mammography, because they are two different things.
Correct.
What are the advantages? And it's not one over the other, but how can one augment what the other is able to do?
Well, they look at the breast completely differently. You know, a 3D mammogram is an X-ray. And, but it used to be we got two films, top to bottom, side to side, even with 2D, mammogram, the digital mammography. That was a great advance over the plain film mammography because now you could play with the contrast and things like that. Mm-hmm. The 3D is called tomosynthesis, and because it's a topography of the breast, it takes multiple images across the breast and up and down, so you can screen through and back through the breast. So smaller things that are hiding in more dense breasts are better seen with 3D mammography. So we're able to visualize things much better than we ever could before on either plain film or digital mammography. Mm-hmm. But it doesn't pick up 100% of breast cancers. And sometimes it doesn't give us good anatomy as well because it's just a plain x-ray. Whereas MRI gives us an anatomy. It's good for looking at the lymph nodes underneath the arm, which we also use ultrasound to do that as well. Mm-hmm. But MRI, they give you a contrast agent, and the cells in the breast take up the contrast in a typical fashion. Well, abnormal cells are more metabolic, and so cancer cells, inflammatory cells, will take up that contrast differently, and then they'll be highlighted on the MRI. So sometimes we can see things that are missed on mammogram, but mammogram picks up more than what MRI does, and that's why the mammogram is the best screening tool.
Yeah, yeah. And I think that's the key, a screening tool versus breast MRI, which is a little bit more than that.
Right. Breast MRI, of course, is a lot more expensive. It's harder to get insurances to pay for it. They're not going to pay for that for screening. And to be honest with you, we've done really well with 3D mammography now with screening. Mm-hmm. But in certain high-risk groups, if you have a family history or you've been diagnosed with breast cancer at an early age, we often get MRIs in addition to mammograms on a yearly basis.
Yeah, yeah. We're talking with Dr. Dan Clark this morning. Breast Cancer Awareness Month is the month of October, and we're going to have this Wednesday series each Wednesday morning, hopefully, right after the news at 8 o'clock. The breast cancer diagnosis is one step. The next step, of course, is treatment and laying out that course of action. And it really is. It's a battle plan, isn't it?
It is. And, I always tell women, your breast cancer is not the same as your neighbor's breast cancer. Even they may be the same stage. We used to just look at size, lymph node status, and if they're spread throughout the body or not. Fortunately, we don't see that often anymore with the awareness and getting early mammograms and everything. The key to treatment is catching it at an early stage. But every early stage breast cancer isn't the same. We look at it at a molecular and genetic basis now. We look at not only the patient's risk for genetics, but also the cancer's genetics. Mm-hmm. And we base our treatment based on a lot of other things as well. We call receptor status. There's a type of breast cancer called a triple negative breast cancer that used to carry, and it's not great, but it's a very more aggressive breast cancer. But it used to be devastating because we didn't have real good options for it. Now we know that the chemotherapy we use for triple negative works. And now we will treat patients who have triple negative breast cancer with chemo first. And so the first reaction is, I just want it gone, get it out of there. Sometimes we have to say, surgery is not the best first option. Mm-hmm. And we have this wonderful arrangement now with the Hillman Cancer Center, and IRMC Cancer Center is in partnership with the Hillman Cancer Center. So every protocol, every chemotherapy, every cancer protocol that's available downtown at the Hillman or McGee is now available right in our parking lot at our cancer center because we have that agreement now with Hillman that it's provided locally.
That's a wonderful thing, isn't it? The way that we're able to integrate that right here into Indiana County, and care that formerly was available only by driving great distances is now available right here.
Right. You used to, if you wanted a second opinion or if you wanted to be involved in research protocols or, see what the latest is, you would have to go downtown to Hillman and see what they had. Now all that is available. The counseling is right here. Treatments are available right here. The oncologists in that center are employed by Hillman Cancer Center. Hillman Cancer Center is a fantastic cancer center. McGee is a fantastic women's hospital. But McGee doesn't set the protocols for breast cancer treatment. The Hillman Cancer Center does. Mm-hmm. And so the Hillman Cancer Center runs what breast protocols are done at McGee. We have those same protocols now here at IRMC. Yeah. So that we meet on a monthly or a weekly basis, doing with our thing called a tumor board, where we discuss cases. It's all the cancer specialists that are there to discuss the cases as well.
You are a surgeon. Changes in technique or in theory in the course of the last 5 or 10 years, or even in the course of the last year, have there been great changes in the way that you go about your business?
There's been a lot of changes over a longer period than that. You know, the one of the biggest changes is how we stage the lymph nodes. You know, we used to do an incision and remove all the tissue under the arm to find out if lymph nodes had cancer in them, because we didn't have any way of finding individual lymph nodes or determining if they had cancer in them. Now we do a thing called a sentinel lymph node biopsy, and where we actually go in and we remove the lymph nodes, but with the new technology, we can actually find individual lymph nodes under the arm. It's very complex, but we can remove 3 to 4 lymph nodes, and that's as good as taking out all the lymph nodes under the arm. And the risk of getting a swollen arm and the complications and the morbidity associated with that are dramatically reduced. You know, the risk of getting a swollen arm is not zero, it's never zero, but it's like 1 to 2% compared to 10 to 15% if you do the full lymph node dissection.
Yeah. Amazing the way that the attack is made.
Right. The other thing we talk about that's big in the news is what we call oncoplastic breast surgery, and that is the concept of doing plastic surgery at the time that you do the cancer operation.
Oh, okay.
And that ranges from all different things, but it's mostly for lumpectomy, where, you know, with a lumpectomy, the true name is partial mastectomy. So people think you're just going in and taking this little lump out, but you have to get a clear margin around it. And that can often create a defect in the breast with dimpling or traction on the breast. So there's a big push around called oncoplastic surgery, where you rearrange the breast tissue at the time of surgery so you don't have that and you have a nice cosmetic closure. And I always laugh because I always say that when I trained, that was just called the right way to do it. It's become a lost art,
Sure.
but I've been doing oncoplastic surgery for 30 years.
Yeah.
You know, and I pride myself, and so does Dr. Bill Moria. She also does oncoplastic surgery. That if you choose to have a lumpectomy, it's a complex counseling session as to whether lumpectomy or mastectomy is the best. But if you choose to have a lumpectomy, we're going to do our best to give you the best cosmetic result.
Yeah, absolutely. We're going to do this segment every Wednesday morning, right after the news at 8 o'clock, through the course of the month of October. We do need to point out to folks, 3D mammography is available, walk-in 3D mammography every Monday.
Every Monday.
And then on other days by simply placing a phone call.
Right. I like to call it Mammogram Mondays. That's not the official title, but it's you can just walk in without a prescription, without a referral, every Monday, either Blairsville or main campus at IRMC, and get your mammogram.
There you go. 888-452-IRMC. Easy number to remember. Very good. Dr. Clark, good to see you again.
You too.
We got to get you on more often.
Sounds good.
It is the voice of Indiana County. WCCS AM 1160 and 101.1 again.